Okay, good morning, good afternoon, good evening po sa lahat. Welcome to our 152nd episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who just discovered us for today, welcome po. Sana po marami po kayong matutunan sa ating very interesting topic for today's webinar. Skin conditions can include inflammatory diseases, infections, cancers, and trauma, and over the years, new technologies have become increasingly available for patients, thus providing safer and faster treatment that are minimally invasive. And ito pong mga approaches na ito ay available na po sa ating Philippine General Hospital. So sana po marami po kayong maimbitahan, makasama ng mga kapatid, kapamilya, katrabaho, kamag-anak po as we delve into the cutting-edge realm of dermatology, exploring the techniques po that we have seen in our opening billboard as well as in our poster po, Mohs, micrographic surgery and laser-based intervention. Yung ito pong micrographic surgery na ito po ay isang meticuloso at very precise po na procedure. It has revolutionized the treatment of skin cancer. So our expert speakers po, no, we bring you nothing but the best po, no. They will be shedding light on the intricacies of this technique, unveiling its exceptional accuracy in tumor removal by preserving healthy tissues. And we'll also be exploring yung ating pong other collaborative and multidisciplinary approaches with regards to optimal patient outcomes, at kasama na rin po sa ating pag-uusapan yun nga pong mga laser-based interventions. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And for this week, mapapansin nyo po, no, si Dr. Susie is out lang po because she has to attend to an important event. But my co-host for this week's Friday po, no, none other than the PGH Coordinator for Training, Dr. Dion Sakdalan. Dr. Dion?
Good afternoon, Doc Raymond, and good afternoon to everyone. I will be sitting in for Dr. Ma'am Susie first, but I hope we would be able to present this very interesting topic for everyone this afternoon. So welcome po to everyone, to all our participants here in the live broadcast of Zoom webinar, and to all those watching via live streaming on the TVUP YouTube channel, as well as on the UP System Facebook page, TVUP Facebook page, and Stop COVID Deaths Facebook page. And of course, all those watching from TVUP Signal TV channel 101. So again, as mentioned by Doc Raymond, our topic for today is the latest updates from the UP PGH Dermatology Department on most micrographic surgery and lasers. And we have very capable and expert doctors from our Department of Dermatology. We will have Dr. Eileen Cobillan, who's the chair of the department, to talk about lasers and its application for skincare. And of course, Dr. Paolo Lizarondo is a consultant of the Division of Dermatologic and Mohs Surgery to talk about Mohs surgery for skin cancer. And then we'll have a reaction from their chief of the Division of Dermatologic and Mohs Surgery, Dr. Charlene Ang Tiu. And of course, for our synthesis and closing remarks, we will have our head of Office of the Expanded Education Training of PGH, Dr. Stella Marie Jose. Okay, so you've seen and in the past, maybe several webinars already, we will still maintain the Stop COVID Deaths, but we'll expand our discussions on the other topics, such as other current COVID-19 problems. O is for other outbreaks, V is for viruses, I is for infections, and D for disasters. And that's why we still kept the Stop COVID Deaths theme. But this levels up to a closer look at our emerging health problems in the community, while we keep an eye out for COVID-19 developments here in the Philippines and in the rest of the world. And since we know that you like to be current with the latest news in health and medicine here and abroad, we have a segment here in the webinar called the News Updates.
Thank you, Dr. Dion, for our very first news update. Scientists have discovered a new way to defeat invisible cancer cells. So an interdisciplinary team of researchers from Magdeburg have discovered a new mechanism that enables the immune system to also eliminate invisible cancer cells, and findings that they have found. So they open up on new possibilities for the development of improved cancer immunotherapies. And they have published this set of findings at the Nature po na journal. So using an experimental cancer model, the researchers observed that a small number of helper T cells can eradicate advanced cancers as effectively as a much larger number of killer T cells. And the helper T cells also able to eliminate cancer cells that had become invisible to killer T cells. How about you, Dr. Dion?
Okay, thank you, Doc Raymond. On my end, we talk about aspartame. According to a Reuters article published on June 29, the International Agency for Research on Cancer, or IARC, which is a part of the World Health Organization, has stated that the artificial sweetener aspartame is a potential carcinogen. Aspartame is commonly used as sugar substitute in various food and beverage products like Coca-Cola, as you can see in our screens, our chocolates, our chewing gum, and some other beverages. The IARC's evaluation is based on a review of available scientific evidence, which suggests a possible link between aspartame consumption and the development of cancer. This classification implies that there is some degree of uncertainty regarding the safety of aspartame in relation to cancer risk. However, it's important to note that this evaluation does not imply a conclusive verdict, and further research is needed to fully understand the potential risks associated with aspartame consumption. And that's our latest news through our news update. Okay, I'm now really excited to listen to our well-picked presenters and what they have prepared for us this afternoon. But before that, I think we would like to hear what the person on the street knows about our topic, Doc Raymond.
Thank you, Dr. Dion. So for our person on the street video, it's something that we prepare each and every week just to set our discussion into context on what knowledge they already know about the topic from the lay people po. But so the questions that we post to the persons on the street are as follows. Narinig nyo na po ba na may laser na ginagamit sa balat? Ano po ang pagkakaintindi nyo sa paggamit ng laser sa balat? At kung hindi pa po ninyo nababalitaan o nararanasan, ano po ang gusto nyong malaman tungkol dito? Please watch this.
Heard a lot of about laser treatments on skin, and then yung mga laser hair removals as well, yung mga non-invasive. And recently, mga like pico laser, yes.
Familiar na ako dun sa laser sa balat. Skin pigmentation, nakakatulong siya para mas maging pantay yung color ng skin.
May narinig na ako tungkol dyan sa pagbubura ng tato. Minsan sa kilay, may mga tato na binubura siya. Ayun lang yung naririnig ko tungkol dyan sa laser sa tato, sa laser na yun.
Really fascinated about this, especially yung carbon laser facial. I'm really fascinated about those kind of things kasi
Isa pa, kapag medyo may age na yung skin natin, syempre medyo nagsasag siya, or may mga type of skin naman na parang may mga hukay, ganon, dahil sa mga pimples or something, ginagamit din yung laser treatment para mas mag-tighten yung skin. So far, ayun yung idea ko about sa laser system.
Ang pagkakaintindi ko dyan, parang kung may gusto kang ipabura, katulad nga yun sa tato, kung gusto mong pabura, naanuhan ka na sa tato mo, pwede mo na siyang pabura. Ayun lang alam ko dyan sa laser.
buckles on skin pigmentation, dark spots especially kapag nagkakaroon ng acne and stuff like that. It leaves marks on your skin, pero with the help of laser skin treatments, it helps lessens actually. Talaga nakakatanggal din siya.
Ang gusto ko malaman siguro kung masakit ba siya o may ano ba sa kalusugan, may epekto ba sa kalusugan yung laser na yan. Hindi natin alam, syempre, teknolohiya yan.
Siguro gusto ko rin malaman yung risk ng pag-laser sa skin. Kasi for example, hindi naman compatible yung laser sa skin ng isa at sa iba. So, yun lang. Interested din ako malaman kung may mga side effects pa ba siya.
Bago gamitin to ng isang tao, anuhin muna, malaman muna ng gusto kung ano yung magiging resulta sa katawan, kung maganda ba o masama. may dudulot bang maganda o wala, ganun lang po.
Siyempre, kung investment yun sa sarili, oo. Lalo na kung magiging maganda naman yung effect nito sa akin. Siyempre, willing din naman ako mag-take risk. And I believe, bago naman mag-undergo ng ganitong procedure, meron silang ginagawang check-up. So, naniniwala naman ako na sa science ay merong magic.
Ang galing. Thank you. Thank you to TVUP for letting us know what the people on the street or on the ground are thinking. I'm really excited. I don't know much about this topic, and I'm sure all other attendees are also looking forward to hearing from the experts. Dr. Raymond, any housekeeping
Likewise,
reminders?
Dr. Dion, gusto ko malaman to like most micrographic surgery at saka sa laser-based treatment pa. But before we do that, meron lang pong very quick housekeeping rules. So for those who will want a certificate of attendance, you will need to spend at least 50% of the webinar duration dito po. So please let us know if you have not received any of your certificates po. The only certificate of attendance that we have not sent out, yung po yung certificate number 150, yung po yung sa may climate change po natin, sea level rise. That's still with the Climate Change Commission, and we're working to make sure that all of the certificates are complete before we send it out to our attendees po. And before we go into the webinar proper, Dr. Dion will go muna into our fun quiz segment. So here's our cute intro video.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Okay, thank you so
Ang
much.
cute.
Making it
Naging mermaid
animated.
na kayo ni Doc Susie.
Opo.
Ano
Thank
kaya
you so
yung
much.
next?
For our fun quiz segment for today, and we have this slido.com. So yung Slido po, yun po yung mga who are watching in Facebook or in YouTube. We encourage everyone to participate in our fun quiz segment. You open up your browsers, type in slido.com, and then you enter the code 6510096 when you are prompted. That's 6510096 for you to be able to participate in our fun quiz. Meron po tayong 3 katanungan for our fun quiz for today. First question, sa anong mga kondisyon maaaring gamitin ang laser sa balat? Is it A, acne scars? Is it B, hair removal? Is it C, vascular tumors? D, melasma? Or E, all of the above? Okay? Ano pa po ito? There are 2 more questions that we will have, and hopefully you'll be able to more actively participate po. If you're having trouble answering questions or accessing the questionnaire, please let us know so we could help you out in that regard. So for our greetings po, we'd like to take this opportunity to greet those who are joining us locally or domestically from the Future Care Center in Batac City in Ilocos, from the RNL Medical and Diagnostic Center in Caloocan City, from the Southern Philippines Medical Center in Davao City, from the DSWD, thank you po, DSWD Haven for the Elderly in Tanay Rizal in Calabarzon Region, from Butuan, wow, Butuan Dermatology Institute in Butuan City in Caraga po. Meron din po tayong mga nanonood all the way from Bataan, from Narvacan, Ilocos Sur, from Manila, Taytana Colleges, Diosdado, Macapagal Boulevard, Pasay City, those from Rizal Medical Center, those from Antipolo, from Arellano University in Pasay, from Cavite, from Lupi Los Baños, from Loma de Gato in Marilao, Bulacan. Maraming salamat po. Those watching also from Diliman University of Rizal System, thank you so much. And those coming in from the Philippine General Hospital, obviously. For question number 2 reads, ano-ano ang mga laser na magagamit sa pag-treat ng mga sakit sa balat? So I hope po you're able to see it kasi I'm seeing on the comment section na parang nahirapan po yata sila makita yung fun quiz. But hopefully you're able to see it dito po sa may Zoom. So question number 2 reads, yun po, laser na magagamit po sa pag-treat ng mga sakit sa balat. Is it A, 585 nanometer laser, B, picowave laser, C, CO2 laser, D, NDYAG laser, or none of the above, or all of the above? Medyo may alam po kami, padagdag na option po para sa inyo. So you already know that we are also being viewed internationally. So we'd like to greet those who are watching us from the Chonin Hospital in Taipei City in Taiwan, from Lunichi Ali University of Blida II in Larba in Blida, Algeria, from the Vinmec International Hospital in Phuoc Ngoc City in Vietnam, from the Thai Hoa Quan Moral Charities in Eunos, Singapore, from the Kingdom of Saudi Arabia, University of Israel, from Sungai Jawi, Malaysia. So yun po yung mga nanonood po sa atin. Maraming salamat po, and hopefully marami po kayong matutunan for our webinar for today. Question number 3. Our third question, it reads, ano-ano ang advantages ng Mohs micrographic surgery? Is it A, mataas ang cure rate? Letter B, bawas ang pagkakataon ng pag-ulit ng cancer? C, bawas ang pagkakapeklat? D, none of the above or wala sa nabanggit? Or E, all of the above or lahat po na nabanggit? So we'll not be putting a close po muna dito sa ating Zoom poll, and hopefully you're able to remember your answers po kanina. We will ask our expert speakers po for the correct answers towards the end of the program as we move on to the webinar proper. For our webinar po, we'll be having our standard panel discussion format, and after our speakers are presented, that will be followed by a Q&A session. Over to you, Dr. Dion.
Okay, thank you, Doc Raymond, for the fun quiz and the Slido poll. So we now proceed to the main part of our webinar, and we're really excited to hear about the basics on laser and its applications for skincare. We would like to introduce our speaker, the chair of the Department of Dermatology of the UP Philippine General Hospital. Please welcome Dr. Eileen Cubillan. Hello, ma'am.
Hello, good day everyone.
Good afternoon po.
I'll share my screen.
Go
Yes,
ahead,
ma'am. Go ahead po.
ma'am.
Okay, so I'll just put this, minimize. Okay, so I'll be talking about some laser basics. So laser stands for light amplification stimulated by emission of radiation. Now, when you talk about light, we mean the electromagnetic spectrum. So on the left, we have the ultraviolet light, then we have the visible and the infrared. Now, there are different types of clinical light. So we use ultraviolet, like for phototherapy, visible light, near infrared, and the mid-infrared. Now, when we talk about light, how do we differentiate laser light from the light, let's say, like from flashlights? So laser light is different in a way that it's coherent, collimated, monochromatic, while that of the one in the flashlight would be non-coherent, non-collimated, and polychromatic. So what does this mean? So when you say coherent light, each beam that comes out of the laser is very specific or identical. So each pulse that we do would have the same effect every time we do the pulse. So this is important for standardization. So we'd have the same effect every time. When you say collimated, it means that each wave is parallel to each other, so it can travel long distances. That's why, in a way, we have like laser pointers or laser guided missiles, or like for skin, it can't penetrate deep into the skin without any diversions. It can be very exact. Unlike that of the flashlight, wherein the beams would be non-coherent. So it's not, that's why it would diverge. So when you flash the flashlight, depending on if you want to direct it to a point, depends on your distance. And then it's also non-collimated because it's divergent, and it's polychromatic because you have a lot of wavelengths, while laser light would be monochromatic. So each laser would have one single wavelength. So here's like, if it's non-collimated, I said that it would be For the flashlight, it would be divergent, while for the laser light, it would be parallel. Okay. Now, there are different kinds of lasers, but each laser would have these three basic parts. You have the pump source, the gain medium, and the laser optical cavity, which is composed of the pair of mirrors. Now, each laser is differentiated by the medium that produces the laser beam. So the pump source is the energy. So when you have the energy, it goes through the gain medium. Now, the gain medium can either be gaseous, liquid, or solid form. So example, if you have carbon dioxide laser, because the medium is gaseous, which is carbon dioxide. If Nd:YAG laser, then the medium is neodymium doped yttrium aluminum garnet, which is a crystal. Now, each laser is also different in terms of its specific range of utility, depending on its wavelength and penetration. So here you can see that the shorter the wavelength, the more superficial it can penetrate the skin. So just here, this is just a diagram of the skin wherein you have the stratum corneum, that's the dead skin layer, followed by the epidermis, and then down below is the dermis. So like here, the excimer laser is very short, so it just can penetrate superficially, while on the other end, you have the 1064 nanometers, which can penetrate deep into the dermis. But what is important for laser is not just the depth, but actually the principle of why it was invented. This was invented by Dr. Rox Anderson. And there's this principle of that there are particular pigment types in the body that attract different wavelengths of light. And these are what are called chromophores. So in the skin, we have this major chromophores: water, hemoglobin, and melanin. So this targeting principle of a specific pigment is called selective photothermolysis. So we know very well about hair removal. So the laser can directly destroy the hair. So the target here is the hair follicle. But the chromophore that the laser is targeting is the pigment in the hair follicle, which is the melanin. So what happens is that the pigment absorbs the laser, the energy, and then the heat builds up and then destroys the pigment. And then the pigment then destroys the hair follicle in the process. So that's why in the hair removal, dark hair responds best. Now, how about this one, this thready veins on the nose, or also the spider veins on the legs? So the target here would be, we want to target the blood vessels. But the chromophore here is hemoglobin or oxyhemoglobin. So this is what is being targeted by the laser. So if it absorbs the laser energy, then heat, then it destroys this pigment and then destroys the blood vessel in the process. So we use this for vascular lesions such as vascular birthmarks, cherry angiomas, again, the thread veins on the nose, also the spider angiomas on the legs. How about this one? So this is pigment here. So the target is the melanin, and the chromophore is also the pigment melanin. So we target this for lesions like melanocytic birthmarks, sunspots, or age spots. And how about this one? We have the acne scars. So the target here would be, we want stimulation of collagen formation. So the target would be the skin layers. And the chromophore here is water within the skin layers. So there's really water within, especially the epidermis and the dermis as well, but more of the epidermis. So we target that, and this is for treating acne scars and wrinkles. So here in the clinic that we have here in the Department of Dermatology, PGH, we have lasers that would hit this chromophore. So again, the main chromophores that we hit are the hemoglobin and oxyhemoglobin, melanin, and also water. So we have the 532 nanometer laser, which targets, as you can see here, it targets the melanin, the superficial melanin, but it can also target a bit of the superficial blood vessels. We also have the deep one, which is the 1064, and it targets down deep, the deep blood vessels, and it can also target the hair follicles. So this is what we use for hair removal. So this one is available with our Nd:YAG laser for the 532 handpiece and the 1064 handpiece. We also have a yellow laser, which targets here the superficial blood vessels and also can target a bit of the superficial melanin. So this is the 585 nanometer laser. And we also have the CO2 laser, which targets the water chromophore. So this is for the wrinkles and the scars. Now we have our latest laser, which is the PicoWay laser, which also has the 532 nanometer and the 1064 nanometer handpiece. But it also has something different from the other lasers available here in the country is that it has this 730 nanometer handpiece because it targets, as you can see here, the melanin, which is in between the superficial and the deep. And also it's the fastest laser here. And why do we want it to be fast is to decrease hyperpigmentation, which I will discuss in a while. So we have that in the picowave laser. So why is the speed important? For the Nd:YAG, it's a nanosecond laser, while the picowave is the picosecond laser. A nanosecond is 1 billionth of a second, but for picosecond pulse, it's 1 trillionth of a second. So when we hit the laser, you'd have a peak power, and once it reaches the peak power, the heat also builds up. And then from then, the heat then dissipates by cooling off into its adjacent structure. Now we want that there will be less of this cooling or involvement of the adjacent tissues because we don't want to hit those. So if it's faster, then we call this part here, the cooling part, the thermal relaxation time. So we want that to be short so that we'll only damage what we want to damage and not damage the adjacent structures if possible. Like example, the thermal relaxation time of a melanosome, which is a pigment in the melanocyte, is 1 microsecond. But a Q-switch nanosecond laser would be 5 nanoseconds. It's even faster. So at least no spread of the heat, which we want. But for a picosecond, it's even faster. So there'll be less of that relaxation time. And also for the picosecond laser, it's a photoacoustic type of destruction, while the one I was talking about is photothermal, where the pigment absorbs the heat then expands the pigment and then shatters it. But for photoacoustic, the pigment absorbs it, and then you have a physical expansion, and then you have destruction of it because of the pressure waves. So again, less of that. So it's more of stress relaxation time for the picosecond laser, while photothermal for the nanosecond lasers. So why is it important? Because especially for our skin type, a risk factor or complication of laser procedure would be discoloration of the skin, where the heat of the laser destroys the pigment of the skin, which can lead to the area of the skin treated to be lighter or darker than intended. Now, another indication for laser procedure would be tattoo removal. So the melanin, water, and the hemoglobin are endogenous chromophores, but tattoo pigment is exogenous, meaning we place them there. So for those that have this and want it removed, then we can do that. Now, lasers emit different colors of light, and different laser wavelengths are needed to remove different colors of tattoo. So remember this procedure in the laser, when the laser beam then is absorbed by the pigment, which then heats up and then it shatters, or in the form of the picosecond, you have the pressure waves shattering the pigment. Now, some tattoo pigments absorb some wavelengths of light better than others. And I'll talk about how do we see light. So different objects absorb and reflect different wavelengths of light differently. So example, why do we see the color red? We see the color red because the object absorbs all the wavelengths and reflects red. So that's why we see it. So similar to the laser, example, if you have a red pigment, a red tattoo pigment, it will absorb all the wavelengths, but it will not absorb a red wavelength. So for a red tattoo, we don't use a laser that would emit a red wavelength. So here we see that for the 532 nanometer laser, it can hit brown, red, orange, and yellow, and sometimes can also hit violet because violet is a combination of red and blue. So we have that for the Nd:YAG and the picowave handpiece that we have in the department. Now, the 1064 here is the one that's very, very good for the black ink. So actually, if you're thinking of having a tattoo, black is the best because that's the one that can be easily removed. So here, this is for, we use the Nd:YAG 1064 and the picowave as well. It says here that for the 1064, it also hits the green and blue, but actually it's not very efficient hitting the green and blue. The green and blue is mostly for the 694 to 755 nanometer lasers. And the newest one now is that of having a 730 nanometer laser, which we have in our picowave laser. So this is good for the green and the blue, which are actually the hard colors to remove in terms of tattoo. And this 730 nanometers is the shortest pulse duration. So you want the fast one. So this is the fastest at 250 picosecond. So it's just here showing that how it removes the blue or the green tattoo. Now, of course, lasers are for rejuvenation. So for wrinkles and skin firming. So how does it do that? Now, there are two kinds of ways of doing this. It can be ablative or non-ablative. When you say ablative, we vaporize the superficial layers of the skin. So here you'd have more downtime because, of course, the superficial layers have been ablated. While for the non-ablative laser, we still can rejuvenate by heating the dermal layers, so keeping the superficial layers intact. So ablative lasers would mean CO2, erbium YAG, okay? And then the non-ablative would be the ND-YAG, the PicoWay. Okay, so before we use this kind wherein we ablate the superficial layers. And then now what we do is this ablative fractional resurfacing wherein we punch microscopic holes, but leaving intervening normal skin. Okay, so it's not really ablating the whole upper layer of your skin, but like it's more fractional resurfacing, which we call it, and which we have it also here in the department using our CO2 laser. For the non-ablative fractional resurfacing, we use the PicoWay laser. Okay. So other complications aside from discoloration of the skin would be if we are too aggressive in the treatment, then of course we have heat buildup, so burns can occur. And of course with that you can have scarring as well. Also, there can be infection, especially for some, you can have bacterial infection, especially for the ablative procedures wherein you slough off the superficial layer. And you can also have like a herpes simplex reactivation for those with history of herpes simplex infection. And of course, ocular injury, because remember the laser can hit very deeply, so it can also affect the eye. So we use goggles for everybody in the room, in the laser room, from the patients to the operators to the doctors operating the lasers. So I'll just show you some before and after that we do. So here's an ND-YAG used for this Venus lake. So it's before and after. And here's just for the striae. And even for the dark elbows, it can also lighten it. So that's all for the laser basics. And we also have the PicoWay laser, which is the only machine actually in the Philippines today. Thank you.
Thank you, Dr. Cobillan. Ang galing, no? Dr. Raymond, yung medyo komplikado na proseso ng laser na present ni Doktora ng very simple way that we were able to understand, no? Naku, ma'am, I would foresee that you'll have a lot of calls and inquiries already from this webinar because of the pictures that you have presented. Thank you very much, Ma'am Eileen. And we'll hear from you again later after all presenters to address the questions from our attendees. Dr. Raymond, we proceed to the next.
Yes. Thank you, Dr. Dion. And thank you to the Chair of the Department of Dermatology, Dr. Eileen Cobillan. Excellent presentation po. For our next presenter, but before we do that po, just a reminder, for today's Q&A session, we really encourage everyone to put in your questions, if you already have them, in the Q&A box po dito po sa Zoom, or in the comment section of the Stop COVID Deaths or TVUP Facebook pages, or in the TVUP YouTube channel. Okay? So our next speaker naman po is also a dermatology consultant, coming naman from the Division of Dermatology and Mohs Surgery from the UP PGH Department of Dermatology. Please give a warm virtual welcome to Dr. Paolo Lizarondo.
Hello, Doc Paolo. Good afternoon.
Hi, good afternoon.
Good
I will share my screen in a bit. Oh, sorry. Okay, so can everybody see my slide?
Yes, looks good, Dr.
Yes.
Paolo. Thank you.
Okay, so good afternoon. I'm Dr. Paulo Lizarondo, and I'm part of the Dermatologic and Mohs Surgery Division of UPPGH Dermatology, and I'm here to talk about Mohs surgery. So here's a brief outline of my presentation. So the main goal of this talk is just to give you an idea of what Mohs surgery is and its common indications, and I'll also provide a brief overview of how we do it and how it differs from the usual surgical excision. And later, we'll also show you some examples of the cases that we have done in the department. So developed by Dr. Frederick Mohs back in 1941, Mohs micrographic surgery is a form of skin cancer surgery that utilizes a modified surgical and histologic processing technique that allows a complete surgical margin evaluation, so which allows us to completely remove the tumor while preserving as much of the normal tissue. So because we're able to examine 100% of the surgical margins, most surgery affords high cure rates for various types of skin cancer. So for specifically for primary basal cell carcinoma or BCC, the 5-year cure rate is 99% compared to 90% when doing the surgical excision. And for primary squamous cell carcinoma or SCC, the 5-year cure rate is 92 to 99% compared to 92% for just surgical excision. Local most data is actually consistent with those rates as well, with a study by Dr. Siriakutan noting a 100% cure rate for primary BCC in a 15-year review study for doing most in St. Medical Center in GC. So does this mean that most should be done for all skin cancer cases? Not necessarily. Most is mainly indicated for skin cancers that have a high risk of recurrence, which include tumors that have already recurred. Tumors also that are located in area 8 or masked areas of the face, including areas around the eyes, nose, lips, ears. Also included in this area are the genital area, hands and feet, and also the nails. And those with aggressive histologic subtypes, for example, like a micronodular BCC, or those that exhibit perinatal invasion on histology. Other clinical characteristics include lesions that have a poorly defined borders like dermatofibroma, fibrosarcoma protuberans or DFSP, those that exhibit rapid growth or with positive margins and recent excision. Other indications for most are skin cancer patients with a prior history of ionizing radiation on the area, those with chronic scar like a margarine ulcer, immunocompromised patients, or those with underlying genetic syndromes like xeroderma pigmentosum. So again, whenever we encounter skin cancer patients, we have to look at these characteristics to assess if Mohs surgery will be beneficial for them. So aside from memorizing that table, one practical way to determine which patients will benefit from Mohs surgery is by using the most AUC or appropriate use criteria. And like most things these days, there's an app for this and it's very user-friendly. So let's do an example to demonstrate how to use it. Here we have a case of recurrent BCC in the right upper cutaneous lip. So here's the app interface. We just select the type of skin cancer. So we just click basal cell carcinoma, and then we just check which area, so area H. So if you're not sure which area the location is, you can just click this question mark. So for like area H, we can just double check that this the upper cutaneous lip is on the area H. So next, we have to note also if it's recurrent or primary. So recurrent for this case, and then we select the histologic subtype, which is nodular in this case. So once you finish answering, the app will give you a score, which is 9 in this case, wherein most is appropriate. If you got a score of 1 to 3, use of most is inappropriate. If you got a score of 4 to 6, use of most is uncertain. So as I've mentioned earlier, Mohs surgery allows us to examine 100% of the surgical margin. So we are able to achieve that by doing a beveled excision of around 30 to 45 degrees usually with a 2 millimeter margin of normal skin. In contrast to a standard excision, for example, a BCC, which is done with 90 degrees with a 4 millimeter margin. So another important thing, aside from the beveled excision, a critical aspect is marking the excision site with nicks usually at the 12, 3, 6, and 9 o'clock position. With the 12 o'clock by convention, usually it's cephalad, and 6 o'clock usually caudal. So the bevel excision is very important because it allows us to flatten the specimen. And this enables us to examine both the peripheral and also the deep margin in the same plane. So once the excised tissue is flat, the tissue is frozen and then subsequently sliced into horizontal section and then placed into glass slides. So the slides then get stained and processed, and once they're ready, we can then examine the slides for any signs of the tumor. So in this sample case, this area is positive. So once we note that this is positive, we have to go back to the map to like the initial excision site. So it's between the 3 and the 6 o'clock position, again corresponding to the positive margins in the slide. So we then get a second layer of just that area, and then to preserve the tissue, and then the whole process is repeated until all margins are clear. So once tumor clearance has been achieved, the resultant wound can be closed primarily with plaster grafts or by secondary intention, especially in cases of shallow defects in the convex areas of the face. If the defects are severe enough, patients are referred to appropriate services such as Opta, ENT, or plastic. So how does this differ compared to standard excision? So in the figure on the left, we see a most specimen wherein again the peripheral and the deep margin can be assessed compared to standard excision, which is processed by a bread loaf technique wherein only representative areas are assessed. So this is a figure that highlights the advantage of doing both. In the upper portion of the figure, we see that there is a possibility of a false negative surgical margin. The bread loaf technique failed to detect the peripheral margin of the tumor, as we can see here. Compared to the unfast or horizontal action technique, which showed positive peripheral and then margin. So these modifications allow complete margin assessment, which leads to high cure rates. So here in UPPGH, with the acquisition of our own dedicated cryostat and automatic tissue stainer, we can now offer Mohs for our patients. So here we see the initial bevel excision being performed by our chief of the Division of Dermatologic and Mohs Surgery, Dr. Angkyu. And then once the tissue is excised, we flatten the tissue, which was also done by Dr. Angkyu with the green gloves, after which it turned over to the Mohs technician operating the cryostat here in the background. So once the slides are ready, here we see Dr. Angkyu checking the margins of the tumor. If found to be positive, another layer of tissue will be removed. Again, the process is repeated until the margins are clear. So once the margins are clear, we can then proceed with the reconstruction. Here we see some examples with excellent cosmetic outcomes. So in summary, Mohs is a skin cancer surgery that allows a complete surgical margin evaluation, enabling us to completely remove the tumor while preserving normal tissue at the same time, which ultimately leads to high cure rate. And we're glad to finally offer this service at the UPPGH Department of Dermatology. So I'd just like to thank Jerson and Mandy for helping me prepare these slides. Jerson is a senior resident member of the Mohs Committee, and Mandy is our chief resident. So with that is all. Thank you.
Thank you so much, Dr. Pau. Dr. Dion, galing ng mga pictures. Something that I haven't
Oo.
seen talaga. Thank you so much, Dr. Pau, and we look forward to you answering questions, especially since I've already received at least one phone-in question about the Mohs micrographic surgery. Thank you so much, Dr.
Thank you,
Dion.
Doc.
Very nice presentation. Thank you for all those graphics illustration. No? It made the discussion easier to understand. Thank you, Dr.
Thank you po, Doc.
Paolo. Okay, so we'll proceed with the reaction from the chief of the Division of Dermatologic and Mohs Surgery. To react on the talk of Dr. Paolo is Dr. Charlene Angtu. Good afternoon. Dr. Charlene?
Good
Charlene
noon,
has a
everyone,
recording.
and thank you for having us today. Now, as a reactor, I would just like to stress and emphasize on some key points which were already mentioned by Dr. Lozarando. Now, most micrographic surgery, of course, has its advantages. We want to conserve as much tissue as we can, but at the same time achieve a higher cure rate. And we do this via frozen section on the same day. So we send the patient home knowing that the tumor is cleared. Now, the main difference in checking the surgical margins is that in the traditional vertical sectioning, we only get a portion of the tissue and slice it like a bread loaf pattern. In contrast, in the Mohs horizontal sectioning, we examine the whole tissue, both the peripheral and the deep margins of the tissue that is being tested. So just to show you, less than 1% of the tissue is examined in standard vertical sections, of course, there's a possibility that there will be that you will miss the skin cancer. In contrast to the horizontal sectioning, like slicing of an orange, wherein you see the peel as the peripheral margin and the deep margin as the orange fruit, as was shown on the slide a while ago here. So here is the horizontal sectioning of your Mohs surgery. So that's basically a big difference because we want to see the whole margin and not just a portion of the tissue. This was already shown a while ago, the Mohs H zone, which is quite important in deciding and choosing candidates for Mohs surgery. So if you happen to have a basal cell, for example, on the back, the patient can be treated with just, the traditional wide excision because you have a lot of tissue that you can get. You can get a 5 millimeter to 1 centimeter margin around it. However, if it's located in these areas on the face, such as on the preauricular area, around the eye, on the nose, on the upper lip, then these are a bit more complicated as you don't have that much tissue to get to make sure that the tumor is clear. I would just like to show you a few cases that I did with Mohs micrographic surgery, especially on the sites wherein Mohs surgery is warranted. So we have a case here of a basal cell carcinoma on the preauricular ear, well, more on the cheek, and this was cleared with 2 stages of micrographic surgery, afterwards closed with a flap. So next case is a basal cell carcinoma on the ear, on the back of the ear, and as you all know, it's a quite complex area where you don't have that much tissue, and it's cosmetically disfiguring to get a big chunk of tissue on the ear. So this was cleared and closed with a linear closure. Next, we have a basal cell carcinoma on the root of the nose and very close to the medial canthus of the eye. So there's also another case wherein Mohs micrographic surgery is the treatment of choice, as we want to conserve as much tissue and not get a whole 5 millimeter margin around it, affecting the medial canthus of the eye. The patient was cleared with 2 stages and closed with a full thickness graft. Now here is an interesting case. It's a recurrent basal cell. You can see it was previously excised on this area. And after a couple of years, a similar pigmented plaque grew on the edge where it was excised. So after stage 1, this is a defect, and it was still positive for tumor on this side of the specimen. And when we did a curette, so clinically in taking the first stage, going back to the photo here, it looks clear, glossy, but then while doing a curette is like a round object with a sharp edge, which guides us as to where there might be cancerous tissue, because cancerous tissue is more friable than normal tissue. And there you see there's a friable portion here, which turned out to be still part of the basal cell carcinoma. So the defect ended up larger than what was expected. But that's okay, because this is what we want to accomplish. We want to make sure that we get everything before closing the patient or sending the patient home. Another case is a recurrent basal cell carcinoma on the nose. You can see where the previous graft was placed on the previous surgery, and then another papule grew on the edge of the graft. The patient was cleared and closed with a biowave flap on the nose. Last but not least is a squamous cell carcinoma located here in the medial part of the infraorbital eye, infraorbital cheek. And this was excised, and the specimen was sent to pathology for a permanent section, came back with a positive margin. That's why the patient opted to have another surgery with Mohs micrographic surgery to make sure that the tumor is clear. And the patient was closed with a full thickness graft. As you can see, most of the cases are located on the head and neck, because these are the areas wherein we want as much as possible to conserve as much tissue as we can, but not sacrificing the clearance of the tumor. So we want to achieve a cure rate with a frozen section, horizontal cross-sectioning of the tissue, and at the same time, conserve tissue, especially on cosmetically disfiguring areas. I think basically that is a take-home message that we have for this service. It is actually the standard treatment of choice for skin cancer, especially those located on the head and neck. We choose the patients who can be candidates for this, and we work with different teams, with plastic surgery, with ENT, with general surgery, and ophthalmology on the closure of defects which are too big, but we want to clear the tumor. If you have any questions, we will be open to the Q&A portion. Thank you for your attention.
Thank you very much, Dr. Ang Chu.
Yes. That's correct.
Very remarkable, no, yung outcome, no, after the excision, and ang galing-galing nung procedure nila. And I think it's really good to make sure that there is really good clearance of the tumor before they're able to close or send the patient home.
Very impressive also that they're able to preserve as much of the tissue or the skin of the patient. I'm curious to know before this, what was ano yung ginagamit nila beforehand. That's what we'll put.
Maybe we can hear from them later.
Really, Dr. Dion. Yes.
Yeah.
So right now at this point we'll ask each of our panelists to please switch on their videos as we prepare for our Q&A session. But while they're doing that, we'll take a very quick break for a special public service announcement today.
Maaari na bang magpabakuna ang mga batang 5 hanggang 11 taong gulang?
Oo, nagsimula ito noong Pebrero.
Nagpapakuna na ba kayo?
Oo, nagpabakuna na kami.
Ay, mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP, the COVID Communication Public Service Announcement, just one of the many creative outputs of the Stop COVID Deaths team to push for vaccination po, no? Especially now that we have yung mga bivalent vaccines now available. We hope you'll be able to share this video clip in all of your social media accounts. So stay safe and stay well. Magpasama na po sa Bakuna Center. Okay? Let's start the ball rolling with questions. Dr. Dion, do you want to start or should I? You're on mute po.
I'm sorry. Okay, I think we can start with some of the questions in the Q&A box from our attendees.
Okay.
There's a question here on are your maybe either Dr. Eileen or any of them can answer this. Now, are your procedures classified as corrective, reparative, reconstructive, or cosmetic in nature? Siguro si Dr. Cabillan.
Yeah, well, for lasers, of course, we have like I said, there are different lasers for different indications. So, example, there are hemangiomas, those big red nodules, like in kids. Although some of them can just resolve spontaneously, but others can be unsightly, so we can use the lasers for that, and also for the acne scars. So, I guess that would be the corrective part, and then we also have the cosmetic part because some would just want to rejuvenate the skin. So it can we do all our indications in a way.
Okay. So very comprehensive yung procedures that our dermatologists can offer, no? From the aesthetic to the corrective to the reparative and maybe to malignant, particularly those presenting a Dr. Lizarondo and Dr. Ratu. Do you have a question on your end?
Follow up
Dr. Ahmed?
to Ma'am Eileen. Ma'am Eileen, how does one get trained in in the use of lasers? Do you have like multiple? Do you have to undergo like a fellowship or something? How do you get that core competency po?
Well, for lasers, there are laser fellowships, so we have laser experts. But most also, if you're a dermatologist and then you've trained in an accredited institution, then laser is also part of the curriculum for residency. As well. Yes.
Okay, so actually the question was probably an aspiring dermatology kasi sabi po niya is matututunan ko po ba yan sa dermatology residency. So that's thank you so much Ma'am Eileen for that question. For the next question that we have and it's the most upvoted question that we have po dito for Dr. Pau, they were really impressed po with Mohs micrographic surgery. So how long do the wounds heal? And then paano po yung recurrence, that sort of thing, Dr. Pau?
Okay. So thank you for that question po. No? So number one for the how long kung bago siya maghino. So like yung it's just like any other surgery or any other procedure on the skin. So there's really nothing parang special in terms of whether faster or slower. It's usually just the same because it's just wound on the skin. So usually yan for the wounds on the face usually around 1 week you can already remove the tumors. And then in terms of the recurrence rate, so in general, whenever we talk about skin cancer, parang the primary method for efficacy of treatment is what we call the 5-year cure rate. So meaning within 5 years, gaano siya katagal na hindi umulit yung cancer or walang cancer. So usually again, based on what I presented, for the primary case ng BCC, meaning it has never been operated on before, usually it can go as high as 99%.
Wow, taas na. Okay.
Mataas. Paano ko naman, Doc Pao, siguro follow up na lang. What if it's a recurrent? Like I think Dr. Charlene showed some pictures of recurrent lesions. I would think mas mababa yung cure rate. And how would you know that the surgery will still be curative?
Yes. Tama po kayo, Doc. No? So usually pag sa recurrent naman, recurrent cases, for example, like BCC, the cure rate is a bit lower. So it's usually around 90%. So relatively good pa rin po. But usually the same procedure pa rin po yung ginagawa natin. So we want to evaluate 100% always of the surgical margin. So we try to do that as much as possible. And then the 5-year cure rate po is again around 90%. So a bit lower po, no? Than it's just primary.
Yeah, but it's still high at 90%, right?
Opo.
So parang worth it pa rin to undergo the procedure if we really want cure.
Exactly. Tapos, add ko lang din po na parang long-term din that it's more cost-effective, no? If we do it. Because like the 5-year recurrence, parang long-term po, no? Mas quality of life as well. That's cost-effective din po siya.
Are there any other modes of treatment that you have to employ after the resection? I mean, the excision or the resection of these kinds of tumors? Meron pa bang dagdag or add-on, for example, na treatment?
So, some cases po, no, when we remove for example, like we have a lesion on the scalp, sometimes po it can be turned positive up until to the periosteum po, or down to the bone. So in those cases po, we can do like adjuvant radiotherapy as well. But in general po, like for example, kung clear na po siya, it would be closed just like any other wound po.
Very nice. Okay. I think there's another question that's related to diagnosis maybe, and still with Mohs surgery. Maybe we can ask Dr. Charlene.
Okay po.
The question here is, Well, she started with saying, I did not know that dermatologists perform surgery for skin cancers. How can we know if what I have on my skin is cancerous? Doctora?
Hello, hi. Thank you for that question. Actually, it's a very good question kasi as dermatologists, di ba, it's a very visual subspecialty. And what we see, usually yun na yun. No? That's why with teledermatology, it really took a parang very successful siya. Now, how do you know if it's cancer? So there are a lot of signs and there are a lot of skin cancers. So the basic or the most common one is basal cell carcinoma. And usually with our Filipino patients, it's the most common is the pigmented type. No? Kaya minsan we get a lot of patients, ay, doktora, parang nag-change daw yung nunal or like it wasn't there before and it just grew. So usually it's a changing mole. But of course, there are different types. No? There's the basal cell carcinoma, just the three, squamous cell carcinoma and the melanoma. So these are the more on the top of the list that we see. And of course, there are a lot of rarer ones. But very important is to get a skin check. Kasi, of course, if may tumubo, especially in the elderly, they're at more high risk for having skin cancers or are transplant patients since they are on immunosuppressants. So their immune system, they can't fight off, if ever they have a new growth or a new skin cancer. So skin check talaga, that's what we advocate to prevent or if ever catch the cancer early. So any growing, usually a papule or it could be flat or it could be raised. If it's growing, if there's history of bleeding, especially without trauma, it bleeds, no, because it's more friable. If it grows in diameter also, medyo irregular yung border. So that's what we usually look out for. The borders, the asymmetry. So madaming mga signs. So kaya, especially for our patients, we want to educate them to really seek consult if there's a growing suspicious lesion. But not all naman are cancer. So we also have a dermoscope. It's actually parang a great tool to help us in guiding us if it's a benign or a malignant growth. Yeah.
Ayun, okay. Papahawa ko sa nunal ko pag may mga may mga mention po ng ganyan eh. Dr. Charlene, question po that we have also received is most micrographic surgery, is that something that's available also for service patients? The number one. Number two, are there any other facilities or institutions that you know that perform that type of surgery po?
Yes, it's available for all patients, no, service and private patients. So we're really excited that it's available in UPPGH. There are other institutions that perform it. So it's actually a subspecialty kasi of dermatology. So only a few perform it, no? But there are several institutions. I think St. Luke's, Makati Medical City, East Avenue. I think those are the ones I know of. But yes, it's available for service patients. And yeah. It's actually, as mentioned a while ago, we choose the patients and not all skin cancers naman. If, for example, if it's on the trunk, you asked kanina parang what are the other, like before how we did it.
Opo.
Before this technique, it's still surgical. So surgery is still a treatment of choice for skin cancer. But the special thing is how you process the tissue. Diba usually even with other services, we do the frozen sectioning, but it's like you cut it bread loaf like 12 o'clock, tapos we send it to pathology or like the 3 o'clock, 6 o'clock part of the tumor. So parang part lang siya. So you don't see the whole 100% and fast sectioning.
Okay. That's interesting. Okay. So the next question naman po that I have, at least that I received, probably someone who mahilig po na gano'n, no, napapatingin sa balat po, no. So Ma'am Eileen, meron daw po bang, when you do like laser-based treatment, etc., meron po ba daw na ibang procedures na hindi pwedeng isabay kung magpapaganon daw po kayo?
Yes, meron. So actually, when patients come in, syempre we evaluate them. We can't just do whatever they ask for kasi what if that's not for them? So we evaluate their skin type, what's the problem. Tas pwede rin most of the time then parang ano ba yung sequence of procedures? Hindi naman pwedeng lahat-lahat. Example, gusto nila ng laser, filler, toxin injection all in one. Hindi naman pwede. So we plan it out for depending on the indication at saka depende din if the patient is the right fit for the procedure. Yeah.
Okay. Thank you so much. Sorry, I forgot to ask Dr. Charlene earlier. Is most micrographic surgery, is that covered by PhilHealth po ba?
There is a coverage with PhilHealth, especially actually malaki yung, well, for service patients, no, we encourage that the patients have PhilHealth kasi covered siya.
Okay.
I mean, partly covered. Depends on the code. Yeah.
Okay. Dr. Dion, go ahead.
Yeah. May question dito on after surgery care. So, the question reads, are there maintenance creams or post-care, reminders after you do surgeries on these lesions on the particular area, like for example, the face?
Yeah.
Siguro
So,
Paula.
Paula.
Charlene or Paolo. Yeah. Anyone can answer.
Oh, Dr. Angkyu.
Okay, yeah. With any surgery naman, of course, proper dressing of the wound. We advise the patients, for example, to keep it dry for a couple of days, and then put moisture with either petroleum jelly or a topical antibiotic if warranted. And there are other creams that we usually advise our patients naman who undergo it, like some silicone gels, which can help improve the appearance of the scar. But of course, it's still surgery and it will leave a scar, but better than leaving a carcinogenic material on your skin. So it will leave a scar. But aside from the creams, there are lasers also, which can improve the appearance of the scar. So a lot of things that, nowadays we're lucky to be in this field, and there are a lot of possible treatment options.
Okay, so that's where the reparative aspect of laser comes in. No? After the curative surgery, then you go repair with laser. There's a question here on the use of laser for cancer. Maybe we can hear from Dr. Eileen.
Normally we don't use lasers for cancer because if it's cancer like skin cancer, especially melanoma and basal cell carcinoma, we wouldn't know if we're able to remove the whole tumor, especially for melanoma. And most would like to do laser removal for moles, even for moles. Like for me, because I'm a dermatopathologist, actually it's my subspecialty. If you do destructive lesion on moles, and then your moles might look different already because you might not be able to remove the entirety because moles actually are deep in the skin. So sometimes when you do superficial procedures on them, then nag-iiba yung itsura lalo. So baka if you do the ABCDE, baka lahat yun mag-fulfill because nga nag-iba na yung itsura niya. So lasers are not advised when treating melanoma, SCC, and BCC. And the gold standard is actually the Mohs micrographic surgery.
Okay, thank you, Dr. Eileen. So very important to have yourself checked if you have such suspicious lesions on your face or any other areas. Biglang nag-appear, you really have to see a dermatologist, for example. And I think a related question here, at least for the laser therapy, Doctora, is the question from another attendee, are all businesses catering dermatologic laser therapy licensed by DOH? And how can the consumer check if they are indeed competent enough to assess and even to treat?
Licensing, I'm not familiar if each one is supposed to be licensed, but I would advise that you check who are doing this, who are the doctors in that center, and look at their credentials. Did they graduate from an accredited institution? Did they have the proper training? So it doesn't mean that you have the MD right there, then everybody's trained. So I think you just have to look at the credentials of those that belong to that center to be safe.
Okay, thank you, Doctora. Any other questions from your end?
One more
Dr.
question. I will pose it to Dr. Angkyu. how often po, and this is related to the remaining question here in the Q&A box, how often do you get referrals for derma for most micrographic surgery, and what should be, let's say, if a physician would want to refer a certain case, what certain signs or symptoms they should be looking out for na dapat ka-refer na po for such intervention?
Thank you. Thank you. Actually, most of the patients referred to me personally are from dermatology, dermatologists also, because we're the first line who sees the skin. So usually patients consult us dermatologists, and then if it's suspicious, we take a biopsy and we send to our colleagues like Dr. Cobillan, dermatopathologist, who will then confirm that it is a skin cancer. So usually ang nagre-refer dermatologist na rin. Other specialties who know about this, of course, like our ophthalmology friends, because they also see tumors on the eye, and it's quite common. We also have basal cell carcinoma on the eye, so they refer to us for Mohs surgery. Because it's actually, if you recall the H zone, that's where we want that Mohs surgery is the treatment for those areas. So for our other colleagues in the healthcare profession, if you have patients that have suspicious lesions at pwedeng skin cancer, it's best to refer to dermatology para ma-biopsy and then discuss the further treatment options if they are candidates for Mohs surgery. So Dr. Lizarondo discussed the AUC, the appropriate use criteria for those who can be treated with Mohs surgery. So not all naman dermatologists lang, even like our general surgery friends, plastic surgery, ENT, they also see lesions which are located on the face. So we work together to clear the tumor, and then if it's really quite large, to reconstruct it. Yeah.
Okay. Doc Raymond, meron na lang akong question, no?
Sige po.
They're asking about possible complications, maybe on both types of procedures that we do, no? For laser, although Dr. Aileen mentioned about some complications already, what are the more common ones that you see, and maybe yung more complicated ones that you see? And then for Dr. Paolo or Dr. Charlie naman, any risks and complications of Mohs surgery? You start off with Dr. Cobillan.
So for laser, like I said a while ago, for the laser, may kasamang heat kasi. So, and commonly we'd have hyperpigmentation, which is a common side effect, especially for us because we have darker skin color as compared to the Caucasians where they have a lighter skin color. So they usually don't get that much hyperpigmentation. So we don't want to superly be aggressive in treatment. Let's say like for melasma, sometimes if you do laser on that one, sometimes baka lalong lumala yung melasma. So we really have to be careful and always know that it's not just one treatment lang. Usually you'd have repeat treatment, repeat session, because under treatment is better than over because of the complication. And again, another one would be too much heat, too aggressive can cause burn and scarring as well. And then, like I said a while ago, it can also reactivate infections like the herpes simplex infection, or if for ablative, then you can have bacterial infection as well.
Okay. Thank you, Ma'am Eileen. How about for Mohs surgery? What are the risks and complications that we anticipate? Maybe Paolo or Dr. Shirley.
Okay po. So for the complications for Mohs surgery, it would be just like any other surgical procedure po. No? So there's nothing parang intrinsic to Mohs surgery or like complication parang complication that specific for it, no? So usually po parang we would expect some pain, would also have some bruising, swelling on the area. But other than that, may mga sometimes din po we can also have some post-op infections, etc. But for the most part po, it's a safe procedure po.
Okay, thank you.
Okay, naubusan na ako ng mga tanong. Dr.
May isa
Kion.
pa. May isa
Meron ka pa?
pang,
Okay,
oo,
go ahead,
meron
go
pa
ahead.
ako nakuha dito. They're asking about the duration of treatment. So whether it's for laser or for Mohs, maybe somebody's thinking about having a procedure done. Maybe we can give them an idea of how long, how much downtime maybe, and then siguro just a range of the cost. So they can also anticipate that. Yeah.
For lasers, it's more of especially like for pigmentation or for tattoo removal. Usually it can't be done in one session, especially if they're multicolors. Then you might not be able to erase all, and then usually treatment would be interval of like 4 weeks. And then, but for rejuvenation, that one it can be like as early as mga 3 weeks. Kasi rejuvenation lang naman. So pwede yun.
And the cost, ma'am?
And the
A range
cost, yun is
maybe?
ano na lang, call na lang the department in terms of the cost. But I assure you, it's much more affordable because we want this to be available to especially our PGH patients. So it's that, and it's also in PGH. So it's we made it affordable. Imagine having a Pico treatment now with the PGH price. So
yeah, excited to book my appointment soon. Okay. Can Dr. Paolo or Dr. Charlene, downtime, a recovery time, and also the cost.
The cost, yeah.
For most surgery, actually, one of the disadvantages, it's longer because we process the tissue on the same day. So it differs. For like a stage 1, maybe about 2 to 3 hours. That's with removing the tissue, processing, and then closing. But if it's like a bigger or a more complicated, like a micronodular BCC, which is like not really predictable, it could take longer, minsan the whole day. So it's really variable. But average, in the study is usually 90% stage 2. There's clearance already of the tumor. So maybe around 3 to 6 hours. And the patient is done as an outpatient under local anesthesia most of the time. And the patient usually waits for the processing of the tissue. So maybe around 3 to 6 hours. For the cost, it also depends on the stages. So like if it's just stage 1 compared to like a 4-stage procedure, so the cost builds up. But of course, it's cheaper then. It's case to case then talaga. Also the reconstruction kasi. So we can't give really like, oh, it's just like this amount. But if you have a suspicious skin cancer, consult muna kasi you might need to know if that's for you. Yeah. Hopefully not for anyone in the audience. But if you have suspicious anything, go to our department.
Thank you, Dr. Charlene. Do you have more questions, Dr. Raymond?
None from me, Dr. Dion. Thank you so much. I think we can move on to answering our fun quiz questions for each of our speakers. Sige. So for first question, this will be for the chair of the Department of Dermatology. So ano pong mga kondisyon ang maaaring gamitin ang laser sa balat? Ma'am Eileen.
Okay, so yes, so acne scars check, hair removal check, vascular tumors check, and then melasma, yes. So all of the above.
All of the above. Thank you so much, Ma'am Eileen. Second question po, laser po ulit, sorry. Forgive po ulit, ma'am. Ano ang mga laser na gagamit sa pag-treat ng mga sakit sa balat?
So yung 585, we can use that for the mga vascular lasers, especially the superficial ones, like yung mga spider veins. Pico Way laser, we can use that for tattoo, for rejuvenation, for acne scars. And then for CO2 laser, also we can use that for the acne scars, also again as an ablative laser for firming the skin as well. And then Nd:YAG, tattoo removal, rejuvenation, vascular tumors as well. So lahat yan.
All of the above.
Okay,
Yes.
okay. Sana wala pong nag-none of the above. Although dito sa ating Zoom, may nag-none of the above po. For our third question, so we'll ask it to Dr. Lazarondo. Ano-ano ang mga advantage ng Mohs micrographic surgery?
Okay. So actually, majority answered correctly. So lahat na nabanggit, no? So mataas na cure rate, bawas yung pagkakataon ng pag-ulit ng cancer or less chance of recurrence, and then bawas din yung pagkakapeklat dahil parang we try to preserve as much of the normal tissue as possible. So majority of our those who watch are correct po.
Okay, thank you so much. So at this point po, I don't have any more questions, Dr. Dion, so we'll move on to our evaluation poll. So for our evaluation poll, we have a 4-point Likert scale. So for this 4-point Likert scale po natin, we have 5 questions. and we open it up to those who are in the Zoom. We do not send out a separate evaluation poll. Ito na po iyon. So if you're seeing it on your screens, we encourage everyone to put in your evaluation. 5 questions po, and as I am reading them, I hope our panelists po will take the opportunity to come up with their maybe 1 to 2 minute po na takeaway message. If there's anything from their talk that they will want the audience to take away, yun po yung kanilang parting message po for this webinar. So I'll read the questions before we go on to the parting messages from our speakers. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language or technical and medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we will not be closing this until the end of the program. Wala na po kaming hiwalay na sinesend out. Ito na po iyon. And Dr. Dion will call in our panelists po for their parting words.
Okay, so it's been a very productive afternoon. I learned a lot. I'm sure our audience also learned a lot from the presentations today. We'd like to ask our esteemed speakers to give their parting words. Maybe we can start with Dr. Liz Rondo, then followed by Dr. Charlene, then Dr. Cobillan. Go ahead, Paolo.
So again, I would just like to thank everybody for tuning in po, no? So again, gusto ko lang din i-echo lang yung what Dr. Angki mentioned a while ago. So whenever we parang may any suspicion tayo for skin cancer, no, make sure to have it checked po, no? So if ever, as much as possible, we want to have it removed as early as possible.
Thank you, Dr. Paolo. Now we call in Dr. Charlene Angki.
Hello, and thank you for this opportunity to discuss the new services that UPPGH Department of Dermatology can offer to our patients. And same take-home message actually is early detection of skin cancer. That's actually like prevention is cure. And if you have any suspicious lesion, just seek consult as early as possible. Because if you hinayaan mo lang, especially during the pandemic, there are a lot of people who just didn't want to go out. And we don't want it to be more complicated. So we want easier treatment with either your surgical excision or Mohs micrographic surgery. Happy Friday.
Thank you. Well said, Dr. Charlene. Now we call in the chair of the Department of Dermatology, Dr. Aileen Cobillan, for her parting words.
Yes, thank you everyone for tuning in and for us to introduce our department, which is actually a young department because we only became a department since 2020. We used to be part of medicine, and so we're evolving. And of course, we still treat, we're still way up there in terms of treating all possible skin diseases, but we would like to introduce that we also have the aesthetic part and also the procedural part of our department. Normally, if you think of PGH, you would think, ay, walang mga lasers yan. Pero now we do have the lasers, and actually we have the only pico-way laser in the country, and which is the latest pico laser now, which is, again, it's the fastest one. And then we also have now a new service, which is the Mohs micrographic surgery. So the department is really evolving, and this is all for the patients that would come in. We'll try to make the rates affordable for everybody so that everybody deserves to have these services. Thank you.
Ayun. Thank you. Thank you so much.
Thank you, Dr. Cobillan. We now probably share the poll results, Dr. Raymond.
Can we have it on the screen?
Evaluation.
Sa bulletin. Okay. So majority of our audience po have participated. So and at least 95%, medyo mataas, 95% of our audience indicated that they strongly agree with each of the statements. So usually what it points out is that it signifies that number 1, they like the topic. Number 2, they like who was talking about the topic. So especially they learned a lot and gained insights po for our webinar. So on behalf of the webinar team, we'd like to thank the PGH Department of Dermatology for being able to share their knowledge on this particular topic po. Dr. Dion.
Raymond, I think they have a video of their department. Tama ba?
Yes. Oo nga pala. Sorry.
We forgot about before we call in our...
Before we call in the one who will be doing the synthesis and closing remarks. TVUP, can we have it on the screen? There we go. Very short video lang po.
2022, the UP-PGH Department of Dermatology outpatient clinic has seen more than 25,000 teledermatology and face-to-face consults alike. These include new and follow-up consults, as well as procedures such as biopsy, electrodesiccation, intralesional steroid injections, dermatologic surgery, lasers, and toxin injections, among others. We also see inpatient referrals from other clinical departments, those admitted patients who need more specialized dermatologic care. We see various skin conditions, including inflammatory disorders such as psoriasis and eczemas, infectious dermatosis, as well as skin cancers such as basal cell carcinoma, squamous cell carcinoma, and melanoma.
Mohs micrographic surgery is a special procedure for treating skin cancers that preserves as much normal skin tissue as possible while ensuring low rates of recurrence of the skin cancer. In our clinic in the past year, we received about 173 consults for skin cancers. The most common cases we get are basal cell carcinoma, squamous cell carcinoma, and a few melanoma patients. Most of the lesions are found in locations with high risk for recurrence. These patients are the perfect candidates for Mohs micrographic surgery. In this procedure, the surgeon will excise the lesion, mark its borders before doing a frozen section. The surgeon will also serve as a pathologist who will check the section under the microscope to evaluate the margins. If there are residual tumor cells in the margins, the surgeon will further excise the areas with positive margins and repeat the process until all margins are clear of cancer. This results in conservation of surrounding tissue compared to white excision, resulting in better cosmesis as well as lower recurrence rates since the margins are examined on the spot.
We have our newest laser, the Picoway laser, which is an ultra-fast picosecond laser that treats acne scars, wrinkles, and tattoo removal. It's also used for benign pigmented lesions such as melasma and solar lentigenes. We also have our CO2 laser, which remains the gold standard for the treatment of acne scars. It is also used for various tumors of the skin such as epidermal nevi, seborrheic keratosis, and other benign lesions. The ND-YAG laser is used for hair reduction and tattoo removal. It is also used for medical indications such as vascular lesions such as hemangiomas, port wine stains, and telangiectasias, and also for pigmented lesions such as solar lentigenes and freckles.
And finally, we have our 585 laser, which is used for various vascular lesions. It's also used to decrease the redness of hypertrophic scars, keloids, and acne scars. Here we have a patient who was born with a port wine stain or a capillary malformation, and after 5 sessions of the 585 laser, we see a decrease in the redness of the patches.
Ang galing-galing.
Thank you so much to the department again. That they even
Thank
prepared po
you.
just to showcase po yung kanilang services at the Department of Dermatology. Dr. Dion?
Okay, I think it's time for our synthesis and closing remarks, and this will be given by our head of the Office of Expanded Education and Training of the Philippine General Hospital. Please welcome Dr. Estela Marie Jose. Hello, ma'am.
Good afternoon, everyone. For our audience, thank you for watching our webinar. And I would like to commend Dr. Eileen Cubillan, Chair of the Department of Dermatology. She was our first speaker, and she spoke on lasers and its uses, like in acne scar, dark skin, small prominent skin veins, and also tattoo marks and hemangiomas. Okay, so she also explained the rejuvenation part, which can be ablative or non-ablative. And I really congratulate the department, especially the previous chair was Dr. Lorna Press, who also who procured the NBYAG, but it is really in the term of Dr. Eileen Cobillan, where nag-flourish talaga yung dermatology department, if I may say so myself. So they were able to procure the PICOA, and now she said that there is a vascular dye laser, vascular pulse dye laser, which they ordered, and it's coming soon. So there's a lot of hope for our dermatology department in terms of the machines. No? So congratulations to Dr. Eileen Cobillan. For Dr. Paulo Lizarondo, he spoke on most micrographic surgery, and he said that it is evidence-based based on 5-year survival rate. 99% of primary basal cell carcinoma were cured, and 92% of primary squamous cell carcinoma versus surgical excision, which 90%, no? So it's 9% lower for primary basal cell carcinoma and 92% for primary squamous cell carcinoma. He also mentioned the St. Luke's has a 15-year review, and 100% of their patients 100% cure rate for their patients with basal cell carcinoma. I hope that PGH will come up with this long-term review also, and we can match this head per head. Okay, so for the most micrographic technique compared with the standard excision, he said that there is a very high cure rate. Now, from Dr. Charlene Q, she expounded on most surgery and the advantages of this. Especially, I'm really impressed that they focus on the peripheral and the deep margins. Also, these are examined well so that there will be no recurrence. And so she also mentioned yung letter H, no? So letter H in the face, and that H is where when the lesion is in the H zone, there is it has the highest probability of recurrence, as she mentioned. No? So for our audience, for those of you who have like enlarging moles or looking moles which are suspicious looking, you can consult our dermatology department, our clinic in the OPD. And also I would like to say that this is a very exciting part of dermatology, because there are so many uses now, so many indications for a dermatology consultation. And for those of you who someone was asking, how do you know if the doctor that you went to is a certified dermatologist? They have a directory, the Philippine Dermatologic Society, and if you look that up, you will see the names of all accredited dermatologists in the Philippines. So you will know if the doctor that you went to is a certified dermatologist or not. Thank you very much.
Well said, Dr. Jose. Thank you very much for a very clear synthesis. I'd like to echo the comment of one of our viewers here. Thank you so much to the experts, panelists for sharing the new services, wonderful insights, and very nice video presentation of the department, and to the SCDT and TVUP for coming up with this informative webinar in today's episode. So keep up the good work, sabi ni Ma'am Lauren Reyes. Thank you, ma'am, for sharing that. Okay, so next week it's going to be an exciting webinar as usual, and I think we will be talking about bivalent vaccines. Tama ba, Dr. Raymond?
That's correct. That's correct. We'll hopefully have none other than the Secretary of Health to be able to share with us patungkol po sa ating bivalent vaccine. So as you know, isa po siya sa mga haligi ng ating programa, and hopefully, and we are very thankful na paunlakan niya po tayo para sa ating webinar for next week, which will be all about bivalent vaccines. But before we conclude our program, we'd like to let you know that All Stop COVID Deaths webinars 151 and pababa po are already archived for viewing at the TVUP YouTube channel po, no? So you just need to go to www.youtube.com/TVUPPH for you to be able to see yung ating 151 webinars, and then after today, it will be 152 webinars na po. And very, very similar din po dun sa ating mga other videos that we have, lalo na po yung mga pinaikli po natin na very, very short and consumable webinars that we lovingly call as SCD Shorts. Yun po ay matatagpuan din po very similar sa ating archived webinars. You go to youtube.com/TVUPPH for you to be able to see this 1 minute, 2 minute webinar short videos po, no? So whether you are waiting for your sundo or waiting for your kape or whatever your juice, kung ano man po yung hihintayin nyo, mahaba ang pila sa may donut shop, you'll be able to learn dito po sa ating mga short videos na we have prepared and culled from the webinars themselves po, no? So this formally closes our webinar for the week. Again, we'd like to thank from the bottom of our hearts the UP PGH Department of Dermatology for such an excellent webinar for today. Marami po tayo natutunan. I personally learned a lot from today's webinar, and we look forward to your company again so ating next Friday from 12 noon to 2 p.m. It's a date.
Together, we can stop COVID deaths.
So keep safe, keep healthy, and see you online.